Welcome to the Ergo2go podcast, brought to you by the Back School and Ability on Demand. I'm your host, Matt Jeffs. We bring interesting people from the world of ergonomics, on-site injury prevention, health, safety, well-being, and a whole lot more. Don't forget to subscribe below and click on the little bell in the upper right-hand corner to get the latest on the overlapping fields of ergonomics, health and safety, risk management, human resources, and healthcare right here on the Ergo2go podcast. Today's guest on our podcast is the co-founder of the Health Rosetta, which focuses on the problem that healthcare has become an extractive industry, taking resources from what drives about 80% of our best outcomes. He's an author of many books, but the one in particular we're going to talk today is his new book, The Opioid Crisis, Wake-Up Call. It outlines how the opioid crisis isn't an anomaly, but rather a logical and unfortunately tragic byproduct of our catastrophically dysfunctional healthcare system. It's my pleasure to welcome back to the Ergo2go podcast author Dave Chase. Dave, welcome back to the Ergo2go podcast. How are you?
I'm doing great. Looking forward to continuing our chat.
It's been very illuminating so far. And again, as a clinician on the inside, your perspective has been so validating. But our talk today is really about your new book, The Opioid Crisis, Wake-Up Call. It outlines how the opioid crisis isn't an anomaly. How did this crisis start? Can you share with us a little bit? And what are some of the systemic causes?
Yeah, I mean, it's involved, and that's one of the challenges is some of the public policy response has been oversimplifying. I mean, basically the media and government is oversimplified the issue, and consequently the so-called solutions often don't really make an impact, or in some cases can even make things worse. There's 12 major drivers of the opioid crisis. And so I break those down in the book, but I will summarize a couple of them. The one that is maybe the least noted, but most important, I think, particularly if you think about how do we get out of this mess, it's nothing created more fertile ground for the opioid crisis than the fact that we've destroyed primary care over the last couple decades. That created this fertile ground where you had these drive-by appointments. And so what can you do in 8 minutes but, refer somebody out, order a test, write a prescription? These poor primary care docs that have been put on this hamster wheel, they're always looking for their exit strategy. And a pill is one of those things. Well, pharma took advantage of that and told, Purdue Pharma particularly, these weren't addictive drugs. Meanwhile, you had from administration things like, you're going to get measured on patient satisfaction, and you're going to get measured on productivity, in air quotes. So it really fed this beast. And we pay for things where there's little or no evidence, like, giving an opioid for a lower back problem. That would be like, putting STP in your gas tank for your wheels being out of alignment or your carburetor not working. And then we don't pay for things that are evidence-based, such as proper physical therapy, which actually, if you look at the biggest on-ramp to the opioid crisis, it's improper handling of musculoskeletal issues. So there's some other factors, but those are some of the biggest ones that really fed this beast.
It's astonishing, and you're making of course, preaching to the choir in my case, but you're exactly right. We all recall the fifth vital sign that we were hearing in the late 90s. And frankly, in my own private practice, and I had an award-winning private practice in North Florida, we deliberately stayed away from the four-letter word pain because, again, as physical therapists, we're function specialists, not pain specialists. And frankly, we didn't want to train our patients to be focusing on that all the time. It's the old joke, don't think of a pink elephant right now. Well, now everybody's got a picture in their mind. So this became a driver that you saw as well. And it's interesting that the primary care system became just this, it's almost like a funnel. Is that safe to say?
Yep, yep. It is a big, fast moving funnel,
Mhm.
to all these other things that drive a lot of revenue for hospitals, but don't drive a lot of health for patients.
You, one of the things we were talking about earlier off camera was the value-based care system, and when you said that, that sent up a little red flag in my mind because of my experience with our favorite colleague, Brian Klepper. He's the one who brought me into the light with RBRVS, the resource-based relative value system and scale, and how it's been used to drive that downstream care, right past primary care and right into the hands of specialists, which of course, I think we're 2-to-1 specialists to primary care in the United States, whereas more successful systems around the world are 2-to-1 primary care to specialists. What do you mean by value-based care, and why is it so important?
Well, it's the value, the opposite is volume-based care,
I
where
get
we're,
you.
where we where we're rewarding just doing stuff to people as opposed to actually looking at things like patient-reported outcomes. Certainly in your work, there's people who are concerned about, can I play with my kids or grandkids, or can I do this or that? They're not necessarily interested in some obscure clinical measure that doesn't mean anything to them. And there's this movement towards evidence-based medicine, which sounds like a good idea, but in a lot of cases it becomes evidence-enslaved medicine, or just an excuse. And something that Brian Klepper, certainly made me aware of as well, is in that system you mentioned, there's a committee that came up with these scores. It's called the Revenue Utilization Committee, I believe, RUC.
Yep.
27 of the 29 docs on this AMA committee are specialists. And the CMS, the Center for Medicare and Medicaid Services, basically rubber stamps this community, their recommendations.
Right.
And so that really created this big problem. And then, and you actually mentioned one of the other drivers, pain as a fifth vital sign, became this overriding thing.
Mm-hmm.
And so it was just this toxic brew that got mixed in and really created this nightmare. And whereas the folks who are, truly living value-based care, they're thinking about the well-being, overall well-being of their patients. And, we can talk about some of the employers who they didn't explicitly have a program, hey, we're going to keep opioids out of our workplace. It's like a great school that doesn't need to teach to the test. It just ended up being a byproduct of proper primary care, which, when I say proper primary care, the fully actualized primary care, like Rosen Hotels, which is the organization I was just thinking about, what do they have on that team? Sure, they've got a doc, they've got nurses, they've got a pharmacist, they've got a physical therapist, they have a health coach, they have a dietitian, they have a chiropractor. So when you have that very easily, and also behavioral health.
Right.
So that is very in one unit. And what you see in places where you have well-functioning primary care, places like Denmark, places like employers like Rosen, folks like my folks are in a Medicare Advantage program that's good. They can address over 90% of the issues that people come into the healthcare system for fully in that setting. Unfortunately, most Americans don't know what that is like anymore because
Yeah.
of how we've devastated primary care and basically turned it into milk in the back of the store, just this low margin thing to get you the high margin stuff. I mean, a typical primary care doc working for a hospital can drive $5 to $10 million of value for the hospital. Revenue, I should say.
Mm-hmm.
And not necessarily a lot of value. I mean, one of the things you were talking about earlier reminded me of how it's 47 times safer to jump out of a plane, presumably with a parachute,
Yep.
than to be admitted to a hospital. And that's with preventable medical mistakes.
Right. Right. I appreciate this, and I apologize for bogging us down in semantics a little bit there, but I'm glad you clarified that, because again, some people are using the term value different than we are right here. When you talk about it, volume versus volume, I totally get it. And the outcomes based is really what we need to be looking at in reimbursement. evidence-based sounds great, but it can be gamed. We know that. It's got to be focused on the outcomes-based, and having, again, a perspective like yours to look at this and be able to tease out these differences are really huge. In terms of opioids, this is something we're going to talk about in our next segment, and that is, how do we get ourselves out of this mess? So might I trouble you to sit tight for a little bit longer, and then we'll finish up with some solutions?
Yeah, absolutely.
Oh, fantastic. Again, I so appreciate it, Dave Chase. To our listeners, you have been listening and watching the Ergo2go podcast. I'm your host, Matt Jeffs, brought to you by the Back School and Ability on Demand. We bring you interesting people from the world of ergonomics, on-site injury prevention, health, safety, well-being, and a whole lot more. People and authors like Dave Chase. So don't forget to subscribe below and click on the little bell in the upper right-hand corner to get the latest from the world overlapping fields of ergonomics, health and safety, risk management, human resources, healthcare, and much more right here on the Ergo2go podcast. So until next time, everybody, let's be safe, let's be smart, and let's be helpful, and let's get to work together. Talk to you next time. Bye-bye.